Hello, I'm Dr. Ken Davis, President and CEO of the Mount Sinai Health System, and I'm with my friend and colleague, Brandon Carr, who is the chair for our health system of our emergency department. We're happy to talk to you today about what we experienced and what we learned from the COVID pandemic. I'm going to start with what happened to us in the spring 2020. We've had two surges, the spring and most recently, but it was the spring that we were truly overwhelmed. At that time, we had the worst day, 2,200 COVID patients across our hospitals. We were scrounging around for supplies, doing everything we could to find adequate PPE, including getting people from, of all places, NetJets to unload a plane in a Chinese airport so that our 2 tons of PPE would leave China and be able to supply our needs. We had care spaces everywhere. We had patients in our atria, we had doubled up in the ICUs, and we had put a tent in Central Park. We had staffing shortages that we addressed through a lot of overtime and a lot of per diem help. So it was like no other time we'd ever seen at Mount Sinai. So what I'd like to ask my friend Brendan, who was, a key part of this, is how did this all happen? What have we learned? And why didn't we have a playbook back then for what was possibly could happen to us?
Thanks, Ken. Thanks for having this conversation today. And we're in a very different place than we were a year ago. And the one piece that I would add to what you said is that we really just didn't understand the disease at all. So the last piece was the information dissemination, the way that our clinical practice was changing, minute to minute, day to day, as we were learning more and more about the disease. Those were the hardest of days, and I'm glad to be through them. Hopefully, through the worst of all of this. When you asked the question about why we didn't get it right, I think about this from two sides. I think about it from what we did or didn't do right locally, but I think you're asking a much broader question, which is about why we didn't have a better strategic lens on this. There's pieces all over through governmental programs that have been built over the years. There's a volunteer registration program. There are teams that go out that get deployed to help during hurricanes. We know about those. There's centers of expertise for special pathogens and centers of expertise for health departments to partner with hospital systems. We actually heard a lot about BARDA during this. We heard a lot of this Biomedical Advanced Research and Development Authority because they were chasing pharmaceuticals to help us to battle this. But really at the root of it, you're asking a question about why the delivery system, why the healthcare system that normally is focused on the business of healthcare couldn't instantly pivot to be in a different business, the business of an unscheduled disease that was overwhelming our system. And that's a really hard question to answer. This idea that there was an easy playbook and we just didn't follow it is, I think, a little bit of an oversimplification.
So what does an answer look like? What really do we have to do going forward so that we are better prepared for the next one?
There's been great energy focused on this across public sector and private sector enterprise since it happened. Obviously, that existed beforehand, but this really has crystallized our sense of the fact that there are things that are done really well in the public sector: testing of mildly ill patients, vaccine distributions, contact tracing, traditional bread and butter public health. But there's stuff that the public sector in general doesn't do that you and I do as a private sector enterprise. Most of healthcare in the U.S. is private sector, and running ERs, running ICUs, running long-term care facilities, and taking care of people who have tracheostomies and need ventilators for long periods of time. In general, that happens within the private sector. So what we need to do to unify it is, many have proposed that we need to create some sort of structure that allows us to seamlessly walk between these two. The language that gets the buzzword is the public-private partnership, so that we can have really candid conversations about who's going to excel and in which space, and how we're going to make sure that crosswalk happens really effectively.
But do you think that the federalist system that the United States is built upon, in which states' rights are so important to some part of the political spectrum, makes it very difficult to have the kind of mandates from the federal government that really would facilitate a good private response.
I mean, it's such a great question. It's because the flip side of that is it's also where our innovation comes from. Trying different models. I think about examples of this. I mean, I think about places that have entities that have done it really well. If you think back to the Reagan era, when the HIV office was created inside of the Domestic Policy Council, it drove global agenda, it drove research agenda, it drove payment structures, it drove culture of taking on HIV and thinking differently about it. It was really cross-cutting. A second example that gets used quite a bit is the way that our energy sector is regulated. Energy generation and distribution is a private sector enterprise, and that functions as an independent enterprise, just like we do in healthcare, that has a coordinated receptor site in the federal government that really helps to set bounds around the expectations of that private sector to function. And we have that in a lot of ways for day-to-day healthcare. You and I spend a lot of time thinking about the regulatory side for our normal practice. We spend less time, I think, and there is less of a clear voice like the one you're talking about, from the federal government that articulates exactly what the expectations are when we are in a surge setting.
So let me put my CEO hat on and ask you a slightly different question. When I think about what we would have to do to prepare for the next pandemic, I think about understaffed ICU, infrastructure that is missing, supplies that weren't available. And what I think is it's going to take legislation. We're going to need money to build the infrastructure that we need so that when the next pandemic just suddenly occurs, we have the resources there. What are we going to do with the underfunded, underserved, under-resourced circumstance that we have? What kind of legislation should we ask our congressmen for?
I think the temptation here is just circling back real quick. There are programs that exist that started to try to build some foundation here. The temptation here is to say, if we just double down and create a one-time or a 3-year grant program as a part of an infrastructure endeavor, maybe that's enough. I think, I would argue that is a really important injection of a priority setting and an agenda, and yes, of course, money. But there's good examples of ways that we've done this in a short-term, long-term approach. The short-term is set an agenda, and I think let's just take one. Let's take what happened with quality and safety after To Err Is Human, the Institute of Medicine report. We identified how many patients are sort of injured by low quality care, by medical errors, and we agenda set. There was a lot of early energy to really understand this issue. There was lots of research funding. There was offices built inside of the federal government, but that there isn't any longer a budget line that says quality and safety. It is baked into the business of healthcare delivery in a dozen different subtle ways. Many of those ways are not always favorites, for C-suites and for healthcare providers, because we're tracking quality and safety. We're connecting our payment to the metrics around that. But we have succeeded in making it not be a line item. We've succeeded in making it be part of the cost of doing business. And I guess I would argue that we need to be thoughtful about the way that we can do that with readiness.
Well, thank you for your thoughts. Let's hope that we don't see this again to the degree that we did in our lifetime. But let's pray that if we do, we will really be prepared, having learned from this last year and a half. Thank you, Brendan, for being with us today.
Thanks so much for the conversation.